Hi everyone, I am Dr. Himadri. Let's talk about pneumonia today. So, what is pneumonia? Pneumonia is basically the inflammation involving the lung parenchyma is called as pneumonia. You can see in this photo that is the inflammation, the red dots are representing the inflammation involving the lung parenchyma, that is the alveoli, as well as the surrounding tissue of it is called as pneumonia. Inflammation involving the lung parenchyma. What may be the cause? It may be mostly due to infection. This infection could be viral infection or could be bacterial infection. According to it, we call it viral or bacterial pneumonia, or it could be due to some aspiration, or maybe some drugs, or maybe due to some radiation, or maybe due to hypersensitivity reaction. If it is due to aspiration, drug, radiation, or hypersensitivity reaction, we call it pneumonitis, not pneumonia. Okay, now viral causes of pneumonia mostly RSV, respiratory syncytial virus, and we can have rhinovirus. You can see this photo, or maybe influenza A, B, or maybe parainfluenza 1, 2, 3. We have adeno, we have coronavirus, we have human metapneumovirus. All this. Okay. Now let's talk about the bacterial causes of pneumonia. Initially, the most common streptococci pneumonia, which is gram positive, as well as staphylococcus aureus. We have gram negative like Klebsiella, pseudomonas. And after these bacterial causes, now we have some atypical organisms like Mycoplasma pneumoniae. You can have chlamydia, or it may be Legionella. Now, please don't forget this organism. This is our MTB, that is Mycobacterium tuberculosis. Okay, Mycobacterium tuberculosis. You can see in the Jadenstein as well. So, if you have this air conditioner, from this air conditioner you are having pneumonia, what could be the probable cause? It is Legionella. Okay. Suppose if you have pneumonia from the bird droppings, the most common cause is histoplasma. From parrot or pigeon, if it is the most common cause is psittacosis. Let's say from school, in a school there are multiple children are having pneumonia. Most common organism, mycoplasma. Okay. We can have other virus causes like metapneumo, adeno, COVID, all this. Okay. Now we want to discuss the causes or the etiology according to the age group. Most common causes we will discuss according to the age group, which are clinically very relevant. Okay, in the up to 3 weeks of age, within the neonatal period, the most common cause always is gram negative organisms, gram negative bacteria. Okay, the gram negative bacteria, the mostly this is Klebsiella, or it could be E. coli, or could be Acinetobacter, like that. In 1 month to 4 years age group, 1 month to 4 years age group, most common is viral cause, mostly RSV, respiratory syncytial virus, followed by rhinovirus. In bacterial cause, what is the most common? Streptococci pneumoniae becomes the most common cause in bacterial cause. Or it could be H. influenzae, but now the H. influenzae become reduced because of immunization, vaccination. The H. influenzae becomes reduced in number. More than 5 years of age, it is Mycoplasma pneumoniae, atypical organism. They causes interstitial pneumonia, atypical pneumonia. Secondly, we can have streptococci pneumoniae, maybe chlamydia pneumonia. But remember, in all age group, we can have virus, that is influenza virus can cause pneumonia. Now let's talk about the pathogenesis of pneumonia. In bacterial cause, anatomically, we can have lobar involvement. Totally one single lobe could be involved, or could be the lobar, that is lobular bronchopneumonia. Please see in the photo. In a lobar pneumonia, we have a single lobe which is getting involved. Here I have drawn the right upper lobe consolidation, or could be, if the lobular involvement, to multiple lobes could be involved. You can see in the photo. Okay. Now, if there is lobar pneumonia, which is very common in case of bacterial pneumonia, the pathogenesis occurs in a specific way. Okay, now let's talk about this pathogenesis. This is your lower respiratory tract with the alveoli. The green one is your naughty bacteria. Bacteria comes and it leads to inflammation of the alveolar wall. Okay, the alveoli as well as the bronchiolar wall getting involved because of this bacteria, and they leads to inflammation, and there is cytokine release. And this cytokine acts on the local blood vessel, and of course what will happen because of cytokine, there will be vasodilatation. Not only vasodilatation, there is the fluid basically leaks from the blood vessel and comes into the interstitial space as well as within the alveoli. Not only fluid, protein as well as your neutrophil. These are your neutrophils with trilobed nucleus. They comes into the interstitium as well as within the alveoli. This is how the inflammation actually starts after the bacteria invades. So there is fluid, there is protein leak within the alveolar interstitium as well as there is neutrophils, and of course you have the bacteria always present from early stage. So this first step of inflammation is called as congestion. You can really understand that there is fluid, there is protein, there is cells. So therefore there is the starting of this inflammation, which happens in 1 to 2 days, initial 1 to 2 days, and this phase is termed as congestion, phase of congestion. Okay, this is the first pathological step in lobar pneumonia. The second step is red hepatization. So let's see what happens as the time passes by. More and more number of neutrophil invades this place, as well as few RBCs from the blood vessel leaks and comes into the interstitium, as well as few monocytes which comes and becomes the macrophages, local macrophages. So this is basically continuation of the inflammatory process. This is called as red hepatization. Question is why it is called as red. I will talk it. The mainly what happens, there is more neutrophil, there is massive confluent exudations because of more cells and more proteins, more fluid, and RBC also infiltrates, and you have the monocytes from blood vessel. It comes and invades this place, and they are basically your macrophages that comes to the interstitium as well as within the alveoli. It is called as red because RBC are infiltrating this place. And why hepatization? Hepatization means liver-like consistency. Because of more fluid and more cells, it becomes solid liver-like consistency. That's why we call it red hepatization. It happens in 3 to 4 days of inflammatory process. Now the third stage is gray hepatization. Why it is called gray? Why? It is called as gray because as the time passes by, RBC basically are disintegrated. As the RBC disintegrated, the color becomes gray. As well as from the fibroblast, there is fibrin deposition. Because of these two things, fibrin deposition as well as disintegration of RBC, the color becomes gray. It happens in the 5th to 7th day of inflammatory process. This is called as gray hepatization phase. Okay. Now the fourth stage is stage of resolution. It usually happens late, that is after 7 days of inflammation. It basically happens. So what is resolution? Whatever fibrinopurulent material is present within the alveoli are getting dissolved. By whom? By macrophages. Macrophage comes and eats all these dead and dying bacteria, dead and dying neutrophils, and all these debris, as well as there could be fibrin, or you may expect to get it outside, or maybe the fibroblast comes and deposits fibrin. That is how, and also the fibrinopurulent material getting reabsorbed as the time passes by. So this is called as phase of resolution. It takes time. It takes from 1 week to 3 weeks. So how the radiological resolution happens? In 90% radiological resolution happens after 3 months. It may also take longer time. Now let's talk about the viral pneumonia pathogenesis. What happens? In viral pneumonia, mostly the alveolar wall, that is the tissue, lung tissue, which is present in between two alveoli, this portion is getting involved. There is edema, there is inflammation, and as well as mostly, as it is virus, mostly T cells and macrophages invades this place. So this is due to some common viruses, that is RSV or rhino. In case of metapneumovirus, there is hemorrhage within the alveoli. In case of adenovirus or coronavirus, there is diffuse alveolar destruction, diffuse alveolar damage. Now let's talk about what are the clinical features. After you know the pathogenesis, how the patient is going to present. WHO classified this condition as no pneumonia, pneumonia and severe pneumonia. What will happen in case of pneumonia? The most consistent feature is tachypnea. Please remember it. Less than 2 months age, 2 months to 1 year, 1 to 5 years, more than 5 years. Less than 2 months, more than equal to 60, 2 months to 1 year, more than equal to 50, 1 year to 5 year, more than equal to 40, more than 5 year, more than equal to 30 respiration per minute is called as tachypnea. So in case of severe pneumonia, what are the signs? Could be cyanosis, could be convulsion. Less amount of oxygen is going to your brain, therefore there could be convulsion. Child could be lethargic, there could be vomiting, there could be dehydration. All these things basically suggest this is a case of severe pneumonia. Okay. So these are the tachypnea is the most consistent feature. Okay. Now approach to a child who basically presents with fever, with cough and cold, with tachypnea. So according to WHO, tachypnea is the most consistent sign, I told you. Apart from tachypnea, the child will have, any person with pneumonia will have fever plus cough and cold. Okay. Now let's talk this in case of viral pneumonia and also bacterial pneumonia. How will you differentiate in history? What will be the presentation? Viral pneumonia, there will be fever. Mostly in viral pneumonia, please remember, there is upper respiratory tract infection initially, followed by lower respiratory tract infection. Therefore, initially the patient will have rhinorrhea mostly. So cough and cold, respiratory distress. In case of bacterial pneumonia, all these things are present, but remember, bacterial pneumonia usually present in in this case the patient becomes much more sick, more fever, more cough and cold. That is the feature of bacterial pneumonia. But and also remember, there is respiratory distress and tachypnea. There is subcostal retraction, intercostal retraction, nasal flaring. All these features are basically much more prominent in bacterial pneumonia, and the child and the patient becomes much more sick in case of bacterial pneumonia. You can see in the viral pneumonia what is happening. Bilaterally patchy opacification involving multiple lobes bilaterally. Therefore, there is bilateral diffuse craves and wheeze you can find. But in case of bacterial pneumonia, in what you will find in clinical examination, let's say there is a right upper lobe consolidation, automatically there will be reduced air entry in the right side, and also there will be the bronchial breath sound. If you percuss it, what you will get? There will be dull on percussion. Okay, and also crepitations will be present. So reduced air entry, as well as there is bronchial breath sound, crepes and also coarse crepes will be present, and it will be dull on percussion. Okay. Okay. Now the pneumonia could be mild to moderate grade pneumonia, or it could be severe pneumonia. If it is mild to moderate grade pneumonia, then we can manage the patient on OPD basis. But if it is severe, then we have to manage it in the IPD setting. Okay, that is, we have to admit this patient. What are the indications of admission? If the child is less than 3 months of age, having severe malnutrition, feeding difficulty, dehydration, or let's say the patient comes and the oxygen saturation is low, that is less than 92 percentile, suggesting hypoxemia. If there is intermittent apnea granting, if there is marked tachypnea, that means for age cutoff it is more than 20 breaths per minute. Or it could be the failure of outpatient, that is OPD management, the patient once again having all those features, then we will admit this patient. As well as if there is complication, maybe due to maybe cyanosis, maybe convulsion, that is reduced amount of oxygen going to the brain, and let's say there is severe respiratory distress because of pneumonia, that is subcostal retraction, intercostal retraction is present, and child is clinically very sick, we need to admit this patient and treat and also give oxygen support as well as IV antibiotics. Okay. So what will how will you investigate this case? Initially, you have to go for blood for complete hemoglobin, CRP, as well as MP, MPD. You know there is fever, and you need to work up for fever as well. You need to send blood culture and chest X-ray. We will discuss about chest X-ray a little later. Okay. If you have blood reports, what you will find in total count? In case of viral pneumonia, usually less than 15,000. In case of bacterial, this is more. There is more than 15,000. Okay. CRP will be more in bacterial pneumonia, and procal will be more in case of bacterial pneumonia. That is how you differentiate between virus and bacteria. More total count, and the defined cell count, there is neutrophilic in case of bacterial. In case of viral, this is lymphocytic. Okay. CRP is more in bacterial. Please remember, procal is positive. Procal is more in case of bacterial. Procalcitonin usually more than 0.5 micron per liter. Okay. Okay. Once you have it, we will discuss about the chest X-ray. Please later. Please be patient. Now let's discuss shortly about the treatment options what we have. In case of mild to moderate pneumonia that we commonly encounter in OPD basis, the treatment is usually amoxicillin, which is given 40 to 50 mg per kg per day, given in BD to TDS dose. Okay. The second line is co-amoxiclav. Okay. Or we can give cefodoxime or cefuroxime. Okay. In case of IPD setting, that is when you are admitting this patient in the hospital setting, what you will give? We can divide it according to age group. Up to 3 months, in neonatal period, mostly this is gram-negative organism. So please give one antibiotic with positive plus negative coverage along with some negative coverage. Okay. So cefotaxime plus minus gentamicin, or we can give as a second line maybe amikacin, or we can give piperacillin tazobactam plus minus amikacin. Amikacin is having very good gram-negative coverage. The first line is cefotaxime plus minus gentamicin. But in case of 3 months to 5 years of age group, what you will give? Mostly ampicillin. Okay. Ampicillin is 100 mg per kg per day, given in BD, that is divided dose. Second line is coamoxiclav, or we can give ceftriaxone. Ceftriaxone is having very good gram positive as well as gram negative coverage. Okay. Mostly gram positive and negative coverage. But in case of more than 5 years of age group, please remember, as the organism is maybe atypical, that is mycoplasma, we need to add erythromycin in this group. Okay. And for streptococci pneumoniae, we are using ampicillin or coamoxiclav. For mycoplasma, azithromycin we have to add in case of more than 5 years of age group. Okay. Now let's talk about the indication of oseltamivir. In viral pneumonia, usually you don't have treatment, but in influenza, that is H1N1 variant, we can try oseltamivir. The condition is it should be tried within 3 days of onset of symptoms, and the dose for less than 1 year of child, 3 mg per kg per dose BD. And we can see from more than 1 year of old child, there is age related cutoffs or age related dose which are present. Okay. Let's say the organism is staphylococcus. Staphylococcus usually cause necrotizing pneumonia, the very severe form of pneumonia. Child becomes very, very sick in this case. The MSSA variant, for MSSA, we have cloxacillin, flucloxacillin along with ceftriaxone. In case of MRSA, we give vancomycin. If it is VSSA, that is vancomycin resistant Staphylococcus aureus, we have to give linezolid. Okay. MSSA means methicillin sensitive Staphylococcus aureus. MRSA, methicillin resistant Staphylococcus aureus. Question is, what is the duration of treatment? In case of when you are suspecting mostly streptococci pneumonia and giving coamoxiclav, the duration of antibiotics should be 7 to 10 days. If it is MSSA, methicillin sensitive, 7 to 10 days of cloxacillin or flucloxacillin plus ceftriaxone. In case of MRSA, uncomplicated case, 14 days. Please remember, if there is complication, we have to give it for long duration, 4 to 6 weeks. Okay. Now let's talk about the chest X-ray part. And We wanna talk it in a little detail. In chest X-ray, please remember, according to differential radiographic density theory, you can have the fluid will appear as white. Okay. In the lung, please see what happens in this case. There is bilateral patchy white opacifications that you can see. These are due to interstitial inflammation, okay, as well as fluid collection. This typically happens in viral pneumonia. Bilateral diffuse fluffy opacifications which are present, as well as you can see that there is the dome of the diaphragm becomes flattened. And goes down, and also 7 to 8 ribs you can count. So therefore there is bilateral hyperinflation of the lung field. Bilateral hyperinflation, that is air trapping is happening, okay. As well as there you can see the perihilar region, there is peribronchial cuffing, as well as white straight lines. These are reticular pattern. So these 3-4 things is a characteristic of viral pneumonia, okay. Bilateral diffuse fluffy opacification, as well as bilateral hyperinflated lung field with peribronchial perihilar peribronchial cuffing along with reticular pattern. You can see in the viral pneumonia, bilateral lung is involved, but in case of bacterial pneumonia, a single lobe is usually involved, okay. So the same patient, within 24 to 48 hours, the patient deteriorated. Why? You can see there is right upper lobe collapse consolidation. So the secondary bacterial infection is usually present in 30 to 45% cases of the viral pneumonia. Please note it. In viral pneumonia, there may be bacterial pneumonia superadded in 30 to 45% of cases, and the patient will deteriorate, okay. Now let's say the bacterial pneumonia. What you will find in case of bacterial pneumonia? To understand it, you need to know what is silhouette. Silhouette means the shadow, okay. Suppose now what I am drawing, the portion of the heart, if you cannot make this portion, that is if it is total becomes white and the boundary cannot be made out, this is due to right upper lobe consolidation. Please remember it, because right upper lobe is anatomically present in that part, okay. If it is right middle lobe and you are drawing the right lower lobe, if it is right middle lobe consolidation, the right border of the heart you cannot differentiate, okay. There will be opacification and it will obscure the right border of the heart. If it is right lower lobe consolidation, the right dome of diaphragm cannot be made out. There will be white opacification involving this part, okay. Now this is the oblique fissure of the left lung, and above it there is left upper lobe, below it there is left lower lobe, and this is the lingular segment of left lung. Now let's say there is opacification which obscured the left border of the heart. What it is? This is due to left upper lobe consolidation and mostly lingular segment of the left upper lobe which is getting involved. And if the left dome of the diaphragm you cannot made out, if it is widely opacified, this is due to left lower lobe consolidation. Please remember this picture, because that is how you will be able to differentiate the different lobes, which lobe is basically involved, okay. Now in this photo you can see right upper lobe consolidation. Please see, you cannot make this upper portion, okay. In this photo, please see, can you make the right border of the heart? No. Therefore this is right middle lobe consolidation, okay. You can see the silhouette, right border of the heart you cannot make it. And in this photo, what you cannot make? Please see, in the upper portion you can easily differentiate, as well as please see that the right border of the heart you can easily differentiate, because there is there's a black line which is going, that is air is going, but what you cannot make is the right dome of diaphragm. Therefore right lower lobe consolidation. In this photo, please see the left lobe, the left border of the heart you can't make out. Therefore what it is? This is probably a lingular segment of left upper lobe consolidation, okay. In this photo, can you make the left border of the heart? Yes, obvious, but left dome of the diaphragm you cannot make it properly. Therefore this is what it is, left lower lobe consolidation, okay. Now once the chest x-rays are over, now let's talk about few complications that you can have in pneumonia. Think yourself, what could be the complications in pneumonia? If the pneumonia is present in subpleural location, this is the right lung. So let's say the pneumonia is present in the subpleural location. Because of inflammation, the fluid, there will be fluid collection within the pleural space, that is in between the visceral and parietal pleura. We call it parapneumonic pleural effusion. Okay, parapneumonic effusion because of subpleural pneumonia. Now let's say another photo. What is happening here? Mostly staphylococcus, which is causing necrotizing pneumonia, and the wall between the alveoli are getting dissolved. They are getting destroyed rather, causing pneumatococcus. There could be lung abscess or maybe empyema. Initially what happens? There is, or it could be empyema, right? Empyema is complication. We can have few other complications as well, systemic complication. Let's say the bacteria escapes from the lung into the blood vessel, that is it enters into the blood vessel. It can cause obviously sepsis followed by meningitis, or from blood circulation it can go to your bone causing osteomyelitis, could be pyelonephritis, or it can cause ARDS, acute respiratory distress syndrome. Okay, thank you.